I'm Stacy Elliott. I am a sexual medicine physician. I've been doing that for about the last 25 years. And I only work with people who have sexual concerns or problems. So although I'm a medical doctor, I don't do generalized medicine. However, in rehabilitation and rehabilitative medicine, sexuality crosses like all planes. So no matter what your condition is or your chronic condition, the effect of that condition, whether it's the condition itself or the medications or spasm or bladder and bowel problems, all affects sexuality. So when we do sexual work at the Blesson Center or GF Strong, it's very biopsychosocial. In other words, we make the patient a whole person, of which sexuality is looked at as a umbrella, and how do we make that person feel functional, and how do we make that person have a quality of life around sexuality. When I first started this field, most of the clients or patients were told that they're never going to walk, they're never going to have sex, and they're certainly not going to be a father or a parent, or shouldn't be, right? What are you doing in a wheelchair thinking you can be a parent? So when all that is taken away from somebody, and then there's a glimmer of hope that some of it you can get back, even it's so empowering for that person. So even when there was a chance to become a biological father, when I first started this field, even if it didn't happen, they were so grateful that they even thought that was a possibility, because everything else was taken away permanently. So, and in sexuality, you get somatic repair to a certain level, you know, sensory and motor, and then that's kind of it. In sexuality, it keeps going. So actually people, it takes years, maybe 5, 7, 10 years. That person's sexuality improves and improves because they're learning all this new stuff, they're accepting their body, they're feeling better about themselves. Maybe they have a partner that worships them regardless. They don't see the disability anymore. This sounds like an ideal scenario, but actually we see it over and over again. The sexual satisfaction as the years go on does get better. So I think when we look at what's important to people with spinal cord injury, obviously, you know, movement is important, but sexuality is on par or even higher than that when you actually ask the question in a research question. So there has to be something human about that, something pervasive, that we all need to feel that we're sexual beings and that we're respected as such. So sexual medicine has been around probably for 30 or 40 years, but it's not a recognized specialty in medicine. In other words, you can't get an FRCP in it and function at that level. So the key to sexual medicine is that it's multidisciplinary. So as a physician, I can do my bit. The nursing, rehab nurses are critical. Occupational therapy, physical therapy, neurologists, gynaes, urologists, everybody's involved in how to complete that person in order that they can have the best satisfying sexual life they can. So from that perspective, sex has been around forever, but the attention paid to it has been pretty dismal, except in the last, you know, maybe 10 or 20 years. And by that I mean that there's actually funding for research around it. We're still fighting, you know, there's the cure versus the consequences. It's still extremely competitive, but the attitude around sexuality has improved. It's okay now. I think with the advent of Viagra, people were sort of saying, okay, this is a very important part of life, I guess we can talk about it. So since then, things have gotten a little bit better, and patients are much more forthcoming than they used to be, and slowly but surely, healthcare professionals aren't shoving it down anymore. They're actually trying to deal with it. So the research that I've conducted through the I-Cord Center and through other granting agencies has allowed us to focus on two main areas. One is functionality in terms of how does somebody with a spinal cord injury become a biological father? There's difficulties with some of the sexual functioning so that it's hard for them to naturally conceive. So we retrieve sperm. The sperm quality is poor, and then we take that sperm and we work with reproductive centers to try to have a baby. What we're trying to look at is there a way that we can get the sperm out that's more physiological? We use two things. One is vibration, very strong vibration, and another one is borrowed from veterinary medicine called electroejaculation. These are non-operative ways of obtaining sperm. So we want to build a better vibrator. We want to build a safer vibrator that doesn't cause symptoms of autonomic dysreflexia. We want to manage autonomic dysreflexia better, and I work with Dr. Krasikov to try to look at ways of reducing autonomic dysreflexia, not just for sperm retrieval, but for any sexual function, including men and women with spinal cord injury, because it turns them off. Dysreflexia is headaches and sweating and, not very pleasant. So that's one area of research, to be able to be reproductively or sexually safe in activities around high arousal levels. The second area is to do more with quality of life and pleasure around losses that you would experience after spinal cord injury in terms of ability to have high arousal, orgasm, that type of thing. And because of the extent of the nerve damage, only about 40 to 50% of men and women after spinal cord injury are orgasmic. So with Dr. Jamie Borisoff, we've been working on trying to get sexual sensations below the level of lesions through neuroplasticity. And we've done some very preliminary work on this using that concept. But, I have to be honest, it's the patients that have taught us. For somebody to have no feeling below a certain level and yet to be orgasmic through learning other areas of their body that become very sexual tells us that there is neuroplasticity going on. There has to be. So the sexual satisfaction that men and women have after spinal cord injury, it's not just related to whether or not they're orgasmic, but what is their overall experience? What is their ability to feel intimate and aroused? So that has to do with neuroplasticity and potentially some new erogenous zones being recognized. So what Dr. Borisoff and I did, and Gary Birch, was to sort of see whether or not there's some potential. What does it take? How many repetitions of being sexually stimulated does it take for the brain to start to recognize that that's a sexual signal versus just a benign signal? So very early work. It's based on the work of others, especially in stroke and things. And I think that there's going to be some interesting work that comes out of that in the next 10 or 20 years. There isn't a lot of centers across Canada, and we are very fortunate in Vancouver to have the Sexual Health Rehab Service that was started by George Saz back in the late 70s, and we work with Mark Nigro, another ICORD fellow. That conglomerate of sort of dedicated people has allowed us over the last 20 years to develop a model system that we're being asked to talk about. We're being asked all the time to do in-services, even in the big hospitals in the States, because they don't have a service. So it's too bad, and it has to change. It just simply has to change. And in Canada, I don't think there's an excuse. We have to get big centers started with these sexual health units from which we can then train other people to, manage the needs. I mean, it's a high priority, and it's not really being managed. And people are starting to get frustrated. The clients have always been frustrated, but even the healthcare professionals are frustrated because it's missed and they feel awkward. So we are developing a sexual health course that starts at BCIT this September, which is at least a beginning, for somebody to go online anywhere in the world and at least learn the basics about this. And eventually that course will morph into a full course, how to be a sexual health clinician. And to me, that's the key. Then they can go anywhere and they can start their service. But you have to have the team around. You have to have the physicians and the OT and the PT around. But then we're dealing with it, and then people can move on. The quality of life piece around sexuality is coming to the fore. It's a groundswell, in my opinion. I think that the patients are demanding it. The medical profession is starting to say we need to pay attention. So I'm very hopeful in the years that I have left, which isn't a lot, before I leave this service, that we have something established. That would be my personal goal, is to have a standardized, evidence-based sexual health management after spinal cord injury that we can put into best practices, that it's up and running. So George Saz was my mentor, and he got us up and running, and before I retire, I want to have Canada up and running.